And in this case, again, I've more and more, when I'm multi-isolating now, is using these winged clamps. You know, you look at a base of the cavity like this, and you know that this is a lot of decay. I think it isn't exposed pulp. Remember, bioceramic, they set with water. Okay, so it being wet isn't a major issue. Hello, so welcome to this week's Friday clinical case, and we are doing a little bit of a U-turn today. We're doing something a little bit different because today's case isn't actually a root canal. You know, if you're a long-time viewer of this channel, you'll know that in the very, very early days, it was more of a general dentistry, kind of being kind to the pulp. This is essentially a video on when you expose the pulp chamber. How do you manage the case? And I'm a bit reluctant to post this case because I know I'm probably going to get a lot of flack, a lot of criticism for this particular case, mainly because of my aggressive, possibly aggressive decay removal, because I know at the moment it's all about preserving tooth tissue, and again I'm absolutely on board with that sort of way of thinking. But a lot of people are leaving a significant amount of decay behind to what you're going to be seeing today. So, as ever with the channel, I'll always caveat with, this is just how I do it. It's not the best way. I'm not saying, you know, I'm an amazing dentist, but this is just an unfiltered way of how I manage the situation. What I do want to say, of course, is that, you know, I'm going to try and justify things, because in this case, I do remove all of the decay from this cavity. But on occasion, I do try and leave decay behind as and when. Of course, this kind of selective decay removal is really, really easy in really large teeth, like say a molar. But, you know, with smaller teeth, it's actually really, really difficult to do this kind of selective decay removal, mainly because it's difficult to see. And of course, your instruments are a certain size. So be kind when you watch this. But also what I would say is I don't mind criticism. So if you think something should have been done differently, or I did this completely wrong, just comment section below. Let's create this great learning environment, because I know I've learned loads. So before we get into the case, what I do want to say is, so 50% of the people who watch these videos are non-subscribers. So very, very quickly, I'll ask you, it's quick, it's easy, it's free. Just hit that subscribe button. If you hit the subscribe button, it pushes me along, it pushes the channel along. If you want to bring the support to the channel even further, we've got a membership program. It's run by YouTube. It's a small monthly fee. You get early access to content. You also get exclusive content as well. So we've got a fantastic endodontic access video on there. Let's get into the case. So I, believe it or not, still do general dentistry. So I'm not a non-specialist root canal dentist. So my practice isn't limited to root canal. So I do take teeth out. I do a lot of fillings. I suppose in a way, a lot of endodontists or specialist root canal dentists, and I might be speaking out of turn here, don't do a lot of restorability checks because it's not really in their kind of sphere of influence. But as a general dentist who takes on a lot of root canal treatment, I'm more inclined to do these kinds of cases now. I'm sure you'll get a specialist endodontist to be typing in the comment section, like, I do, but just mainly from the specialists that I know don't tend to like to do this. They like to understand that the root canal, the tooth is restorable, and then they just have to do the root canal. But this is a patient who just attended for a new patient assessment. We found that the upper left 5 here had significant amount of decay in it, and obviously the patient was warned about this, about this, the type of the decay, but I reassured the patient that this is a thing that I love to do. So I like to try and save teeth. I love the pulp, so I like to try and save the pulp as much as possible. So the first thing we're going to do, of course, really important, is place rubber dam. In this case, I'm going to multi-isolate the tooth, mainly because obviously there's this distal box. So if you've just single isolate the tooth, you will be able to get the sort of matrices around the tooth. And in this case, again, I've more and more, when I'm multi-isolating now, is using these winged clamps. And you know, obviously doing the 4 holes here, but placing the wing clamp on the furthest one back. And what I would say, if you've never been on a rubber dam course, or you're not very good at rubber dam, get yourself on a course. It's probably one of the best things I ever did, ever. And what it teaches you is that you use your nurse as someone who stretches the dam over, and she basically, or that she or he helps you out. But in this case, I managed to get the rubber dam on by myself. And another thing you've got to do, of course, you've got to floss the contacts. And what you're kind of doing is you're not sort of flossing between them sort of willy-nilly. You are trying to push or invert the rubber dam into the gingival sulcus. And of course here we're just going to move the rubber dam over these wings here, and then give it a little bit of a stretch around, so we make sure that the rubber dam is fitting nicely. And sometimes, you know, you can give the rubber dam clamp a little bit of a wiggle, but you know, I think occasionally that can sort of dislodge everything that you've done. So I'm happy in this case that I'm not using extensive amounts of irrigant like I would do in a root canal. So I know that the tooth behind it is untouched, so I'm going to use one of these wedge guards here. So this is kind of like a bit of a wedge which opens up the contact between the 2 teeth, and also it's got like this kind of metal sort of plate which stops the fast handpiece or the burr from touching the adjacent tooth. And of course, what we don't want to do, we don't want to damage the tooth, but in the same vein, we want to make sure there's a surface which is smooth enough to get a good contact point. So if you've made like a little bit of damage in the adjacent tooth, to get a smooth contact then with that tooth is going to be difficult without you polishing it even further, so you're further damaging the tooth. But before I have a little feel around this, and I think to myself, I'm about to drill, and then what I notice is the rubber dam sheet is in the wrong position, so the patient's kind of biting on the bottom part of this. So I do this a lot. I place the rubber dam on and I just check where the frame is, and I give the top part, or where the nose is, a little bit of a fold, and then I place the rubber dam frame back in this position. And what this does is it kind of, you know, it's quick just to get the rubber dam sheet on really quickly in this case, and then once it's on, you can kind of work out where the frame is, and you want to make sure that the rubber dam isn't over the patient's nose, because the patient might be able to breathe, but also it can be a bit overwhelming for them. So we look at the tooth and we can see that we've got intact enamel, kind of, and this needs to be broken. And at this point, I don't really know what the extent of the decay is, although I do know from the X-ray that it's pretty bad. But I don't really know the extent of the difficulty of this. And straight away when we access the tooth, we can see that it's really deep. You look at a base of the cavity like this, and you know that this is a lot of decay. You've got to be very careful about the pulp. And of course, what I want to do is I want to remove the least amount of enamel as possible without leaving it undermined. Of course, if you have undermined enamel, it can break away. So I'm just removing sort of the edges and having a little look, and then now I'm going to use a slow handpiece rose head here just to remove some of the decay. And again, the first thing I notice with this is this drops in. So this is significant softening. This is significant decay. And then I've given this a good old clean out with the rose head, and I'm still got loads and loads of decay left. So I know this is really deep. So I'm going to remove some more of that undermined enamel, and then I'm just going to be, in this case it's hard for you to see, but I am using the rose head, and it's a ceramic as well because it doesn't generate as much heat, so it's not going to cook the pulp. And I'm trying to go around the circumferential part of where the pulp might be. But again, it's easier said than done, isn't it, with a tooth which is really small. And we can see here that it's improving here, but there is still a little bit of decay. The ceramic burrs, I've only got them in one size, so in this case, I'm going to have to use a larger size. It's stainless steel in this case, so just got to be careful about cooking the pulp, creating too much heat. And then once I've feel like I've removed enough, with a slow hand piece. I'm going to go in with an excavator, just have a feel around for some of the decay. But, I just feel like most of the decay has been removed, but I'm really worried about the extent of the decay. I'm just going to use a little bit of Caries detection dye. Now, I used to use this never, and then I used this a lot, and now I've started to go back to using it in just very, very selective cases. And, when we place the Caries detection dye in here, we can see that it's dyed almost all of the inside of the cavity. So we just got to use that with a bit of pinch of salt, okay? Because this could just be remaining flakes, could just be the surface. So I'm just going to use my slow handpiece here just to remove around the outer edges. But remember, it's difficult because, it's a small tooth. And then as soon as I just give it a little bit of a clean up with a fast handpiece, I notice something, maybe, possibly there's a pinprick exposure here. Now, I'm not too sure if this is an exposure, if this is the remaining dye, if this is a little bit of sort of dentin which is flaked away. And the worst thing for you to do here is just to jam your probe in it straight away, because if you do that, then if it was just a thin amount of dentin, then you're going to expose the pulp unnecessarily. But also on the other hand, if it's a flake of sort of infected dentin, you don't want to be leaving it there. So in this case, I'm just having a very, very sort of gentle feel around with my probe. I think it is an exposed pulp. So straight away, I'm just going to irrigate with bleach. And this is, it's kind of looking at a case and then trying to look into the future about what's going to happen, because obviously if the patient didn't have rubber dam on, I know you should be using rubber dam with everything, but in this case I couldn't have just picked up bleach straight away. And once we've cleaned the interior, the cavity, we can see that it is a pulp exposure. Now we're kind of at a bit of a precipice here, because there's an argument to say we remove some more of the dentin and we remove some of the infected the pulp, or do we leave it in place? And this is possibly another sort of bone of contention. The first bone of contention is how much decay I've removed in the cavity, and again, if you disagree with that, then that's fine. But another case is that I've done a lot of pulp caps and I've removed a lot of so-called infected pulp tissue, and what I have noticed is that these cases more often than not come back in severe pain. And just anecdotal evidence, so none of this is scientific, just based on my own experience in practice, I feel like just leaving the pinprick exposure there and not removing some of the pulp tissue is probably gets better results. But that is just my opinion, and that's just just anecdotal, so it's non-scientific at all. So I'm going to do a selective etching technique here, because I'm going to place a bioceramic putty over this exposure, but I want to make sure that I've etched the tooth, because placing the bioceramic putty on first and then etching can wash away the bioceramic putty and it makes a massive mess. So what you'll notice here is when I place the etch on, it's not actually touching the base of the cavity, so I'm just etching the enamel. And when we look a little bit closer here, we can see that it is much clearer. So to place the bioceramic putty, what I am going to do is I'm going to just make sure that I am making the inside of the cavity moist, because placing a bioceramic putty in a dry cavity is really, really difficult. But as I place this bioceramic putty, I actually notice that the base of the cavity is probably a bit too wet, and it's not the end of the world. But what I do have to do is I have to kind of dry this a little bit, because I feel like it's just going to make a massive mess. Okay, so just use a bit of air drying. Remember, bioceramic, they set with water. Okay, so it being wet isn't a major issue. And like I said before, trying to place a bioceramic putty into a cavity is really, really difficult, especially if it's dry. But even if it's wet, the bioceramic has this sort of propensity to stick to your instruments rather than the cavity floor. But I'm using a succession of different instruments here. So I'm using a plugger here with a sort of flat edge, and once I've sort of placed that into the cavity, I'm now using a ball-ended burnisher just to place it. And it's kind of, at the moment, the edges of this bioceramic, there's a bit of a ledge, and what I want to do is I want to try and create this kind of like nice sort of contour, so there's going to be no air pockets essentially when we place the flowable. So once we have placed the putty, I'm ready to do my sectional matrix. But what I do notice in this case is that the sectional matrices doesn't get between the tooth very well. So what I'm going to do is I'm going to place a wedge between the two teeth, and what this does is just opens it up slightly. Now I could just remove the contact, but I'm just using my common sense here. I feel like I've removed, I've opened up the contact with this wedge, and now this sectional matrices just sort of goes into position quite nicely, and you can see it's nicely and down. Then I'm going to place my wedge on first before I place my sectional matrices ring. And when we have a look here, we're using Palladent, of course. We can see when we look at the tooth that it's not quite adapted on the palatal surface. So I've got a neat little trick here that I like to place PTFE to try and push the sectional matrices against the tooth. Now, of course, you could just polish it off next time, but the problem with polishing it off next time is obviously it takes more time, and also you got this difficulty in ruining the contour of the tooth. I'm now ready to place the bond. In this case, I don't want to place the bond directly onto the bioceramic putty. So what I do is I get a big dollop of bond on the end of my brush, and I just place it in the upper part of the cavity, and then I use air to blow it into the cavity. Again, bone of contention, probably not the best thing to do, which is the way I do it. We bond it, and then we're going to use flowable composite here. This is a bulk flow. So although it is a bulk flow, I don't want to be creating this huge layer, mainly because what you want to be doing is you want to be getting the flow over the liner, shall we say, or the bioceramic putty, and then once you have sealed all that up, you've got a little bit of latitude then to build up your box. And it's always important to build up the box first, mainly because of the C factor. So you don't want to, if you were to fill this completely with composite, when you set it, it would shrink, and then you wouldn't have a really good contact. So you can see here that I'm using an instrument here. It's like a rounded end burnisher, and it's just creating this sort of distal box, but also I'm getting that kind of rounded beveled edge as well, so you've got that kind of nice sort of contour of the tooth. I'm just using a very, very thin probe here just to make sure I keep that rounded profile on the distal box. And then essentially it's just once you've placed the distal wall, it's just filling the rest of the tooth with composite and just creating that kind of final contour, maybe putting a little bit of occlusal anatomy in there. I'm not really a massive fan of that, only because I'm probably not very good at it. Give it a little bit of a contour around, and then I'm going to remove all the sectional matrices. One of the really satisfying things about doing fillings is when you find it difficult to pull out the sectional matrices, because you know then that the contact point is pretty good. But what I notice is we got kind of a bit of a flash with the bond and some of the flow, so I'm going to get a bit of a clean out. And I want to do a final adjustment before I do remove the rubber dam, because I want to do as much as possible in the rubber dam, because I've got a bit of control. But we're just going to do our final check, occlusal check here. The patient had suggested that the occlusion's pretty good. Again, I'll probably get crucified here on the comments because I hadn't checked the occlusion before I got the patient in. But overall, the patient was happy. And essentially, you sit the patient up. Of course, the patient was aware that this could happen, and you just give him the rundown of everything. You tell him, you say, the tooth is exposed, and there's a possibility, you have a bit of pain, but what's in your best interest is we try and save the tooth. And I would say 100% of the time, the patient agrees with you. And if the patient didn't agree with you, then you say to the patient, well, let's book you in for an extraction, or a root canal. But it's a really really important to talk about risks and benefits. So it's really important to gain consent essentially before you do these things. So try and look at the X-ray, try and look into the future and just anticipate any problems. And overall, I hope you've liked this different type of video today, not a root canal, and a little bit of insight into my other practice in life. If you have any comments and questions, please comment in the section below. I know that this video is going to expose myself to a lot of flack, but bring it on. You tell me what you think was wrong with this case, and I can count. I've lost count the amount of times someone has said something in the comment section below, and that's completely changed my practice. So you comment in the section below, tell me I'm wrong, and we can all learn from these videos. And I'll see you in the next video next week. Bye bye.